Hello, my name is Gani Fananavizir, and I'm going to be talking about liver Doppler. So when we think about liver Doppler, I think there are a few things to talk about that may help us organize our thoughts on making a diagnosis. And the first thing is becoming familiar with the terminology with flow direction, phasicity, and pulsatility, and then talk about what are the differentials associated with differences in pulsatility. So let's start with flow direction. And flow direction, you can either think of it as towards versus away from the transducer. So red is typically towards the probe, whereas blue is typically away from the probe. And we can think about things in that particular orientation as far as flow direction. But the other way we can think of flow direction is it antegrade, which is flow in the expected direction, or is it retrograde, which is flow in the reverse of the expected direction? And that's probably the better definition to go by when we're talking about the liver. Is the vessel antegrade, again, flow in the expected direction, or retrograde in flow, which is flow away from the expected direction? So let's talk about things. Normally, when we're looking at the hepatic artery, and you can see the hepatic artery right here, it's going parallel to the portal vein. So the bulk of this is the portal vein, but you can see there's an area of almost orange that's just anterior to the portal vein, and this area is higher velocity. This is the hepatic artery. And normally the hepatic artery is always going in the forward direction, both during systole as well as during diastole. So forward direction is something you would always see within the hepatic artery normally. Now the hepatic artery supplies about 25% of the blood flow to the liver. And the way that we talk about the resistance to the hepatic artery is we use the resistive index, which ends up being your peak systolic velocity minus your end diastolic velocity, all that divided by your peak systolic velocity. And normally the resistive index within the hepatic artery is somewhere between 0.5 and 0.7. Here's an example here where we can see this is an abnormal hepatic artery. Remember, we talked about how hepatic artery is always supposed to be in the antegrade direction. It's always supposed to have antegrade flow. But here you can see during the end of systole, we can actually see some reversal of flow. So this is intermittent retrograde flow, which is always abnormal when we're talking about the hepatic artery, and usually indicates some kind of very high resistance within the liver itself. Now, this is an abnormal case here where there's actually reversal of flow during systole and diastole within the hepatic artery. And this usually indicates some kind of shunting that may be going on. So this would be a good reason to maybe get a CT angiogram or an MR angiogram to be able to further assess not only the hepatic artery, but why this hepatic artery may be reversing and causing shunting. Now, the portal vein normally always has antegrade flow, similar to the hepatic artery. And so this continuous antegrade flow is shown, but you can see that the phasicity associated with it is different from the hepatic artery. It's got more of this kind of undulating appearance. The hepatic artery supplies about 75% of the blood to the liver. So let's take a look at some abnormal ones. Here we can see this is intermittent retrograde flow of portal venous flow. We can see here we've captured a particular moment on the color Doppler where it's looking like it's going in the forward direction. But if we happen to have caught the image during this portion here, it would have appeared blue. So this intermittent going from red to blue is an indication of an abnormal flow within the portal vein, and this would be intermittent retrograde flow. And then finally, in this example here, we can see that there's continuous retrograde flow, that this is flowing in the blue direction. This is away from the transducer, and we can see that's not in the correct direction. So this would be retrograde flow. This is shown to us on this spectral Doppler image where we can see this retrograde appearance of flow out, moving out of the liver itself. And then there's another thing to think about when we're looking at the liver. Sometimes it can appear almost like a spiral appearance here. This is referred to as helical flow, which can be a normal appearance of flow. That flow within the portal vein, we typically think of it as moving in a continuous column, but actually it can spiral into the liver itself. And so it's always going in the forward direction, but because it spirals into the liver, it can sometimes give this kind of candy cane appearance of the of the portal vein itself. And here you can see it on a cine clip, how it looks like there's flow going in the reverse direction, but really this is just a column of blood that's kind of spiraling in, and so certain portions of it can look like there's reversal of flow. Now the hepatic vein is much more complex than the portal vein and hepatic artery. And so I thought I would just create this kind of illustration to show what it's like. And when you're thinking about hepatic vein or the IVC, you just imagine yourself right here where this asterisk is, and here's the right atrium, here's your SVC, and here's your right ventricle and your pulmonary arteries. So you're really thinking about the right side of the heart, and you're thinking about placing yourself right here. And let's kind of put some red blood cells within this diagram to see what happens. So the first portion of the cycle is this right atrium here is going to contract. That's going to send most of the red blood cells into the right ventricle, but a certain number of these red blood cells are actually, as this squeezes, are going to go up the SVC or down the hepatic veins or down the IVC into the hepatic veins, because there's actually no valve here. So this initial upward inflection here of the tracing of the hepatic vein is caused by reversal of flow, of blood flow from the right atrium into the hepatic veins. Now, as this maximally contracts, the A wave eventually slows down and stops, and then we get right ventricular contraction. And when the right ventricle contracts, there's going to be relaxation of the right atrium and downward movement to the right ventricle, and this kind of sucks blood back into the right atrium, and so there's rapid movement from the hepatic veins into the right atrium, and so you get this S wave right here indicating systole. And this is going to be your largest movement of blood into the right atrium, so you're going to see this quite large S wave right here. Now then what happens is you get increased blood pooling in the right atrium. This leads to decreased flow into the right atrium, and so you can see this S wave is slowing down, and then you have the closed tricuspid valve as well. Then you have the increased pressure in the right atrium, leading to low or reverse flow in the right atrium. This can sometimes occur below the baseline, sometimes this can go a little bit above the baseline, and there's decreasing pressure in the right ventricle from relaxation. Then you have the tricuspid valve opening up. There's lower pressure in the right ventricle compared to the right atrium. This leads to the tricuspid valve opening, leading to increased flow into the right atrium. So you get this D wave coming right here. And then eventually you get increased flow in the right atrium and right ventricle, leading to higher right atrial pressure and then decreased flow. And so you get this portion of the wave. So these are referred to as your ASVD waves, which you can see here on this spectral Doppler tracing. Here you can see the A wave, the S wave, the V wave, and the D wave. It's also important to note that in some cases, normally the V wave can actually be above the baseline, as we talked about before. So there are portions of it where it's below, sometimes it can be a little bit above, and both of those are normal. So let's now talk about phasicity and pulsatility. And so here, imagine that here's a baseline for a spectral tracing, and let's see how we would describe different types of waveforms. So in one where you're getting a particular kind of flat waveform here, let's see how we would describe it. This, as far as phasicity, would be no. It would be non-phasic. There's no phasicity to this. When we look at inflection, we're talking about acceleration changes. So does it actually change its direction? In this case here, it doesn't. There's no inflections in here, so this would be called aninflectional. Let's look at another example here. Here's something here. Here's a particular waveform here. How would we describe it? Is it phasic? Yes, there are changes within it. Inflection, are there acceleration changes? Yes, it changes its accelerations, and this would be di-inflectional. There are 2 inflections on every cycle that we look at. So we look at one cycle, we can see this has 1 inflection and then a second inflection here, and so this would be di-inflectional. Now, when we talk about the change in flow direction, we can see that this is still always above the baseline, so this would be referred to as unidirectional. So it would be di-inflectional, unidirectional. The phasicity is a little bit more complex because sometimes this is referred to as biphasic or sometimes monophasic, depending on the definition of whether or not you're talking about does it change its direction of flow. So either one of those would be appropriate depending on the definition of phasicity. And then finally, pulsatility we look at and say, is this a normal amount of phasicity would determine our pulsatility, and in this case here, the pulsatility would be normal. Now let's look at the same waveform and now put it above and below the baseline. What's changed here? Well, the phasicity is still there. It still has phasicity. It's still di-inflectional. You have 2 acceleration changes. As far as change in flow direction, we can now see that this has gone from unidirectional to now bidirectional. The phasicity here is always going to be phasic because now it's lining up that you're getting it above and below the baseline. So this would be biphasic, and the pulsatility here would be normal. Now, if we change the pulsatility here you can see that we've taken that previous one and we've increased our pulsatility. So this is still phasic, this is still di-inflectional, it's still bidirectional here. This would be biphasic by both definitions, but here the pulsatility would be increased. Now let's look at what it would look like if the pulsatility decreased, and here we can see it's a more flattened appearing waveform, and so here the pulsatility would be decreased. Let's go back over it. Is there phasicity? Yes. Are there acceleration changes? Yes, it's di-inflectional. Are we changing flow direction? No, we're not, so this would be unidirectional. Again, this would be monophasic or biphasic depending on the definition, and this would be decreased pulsatility. So let's look at how this impacts our waveforms within the portal vein, within the hepatic vein. So phasicity and directionality of the portal vein, we know that the portal vein is supposed to head towards the liver during the whole cycle itself. You do get some minor respiratory phasicity, which can occur, but most of the phasicity that you can see is actually from the cardiac motion. The hepatic sinusoids will dampen the pulsatility related to cardiac motion, but in this particular example, I superimposed the hepatic artery on the portal venous waveform, and you can see that every time there is systole, there's also kind of a rise in the portal vein. And so the phasicity really arises from the cardiac motion itself. Now, how do you measure the phasicity? Well, there are various methods to do so. One of them is called the venous pulsatility index, which I kind of like because it's similar to our resistive index, where you take the peak, you subtract the min, and then you divide it by the peak. So it's the max minus the min divided by the max. And normally what you should see is a pulsatility index of about 0.5. Normally you expect there to be about half the height during the minimum portion of the cycle. So let's look at some examples here. Here's one where the portal vein has increased pulsatility. We can see that this is increased pulsatility. We can also see intermittent reversal of flow. So this is bidirectional. This is a biphasic waveform with increased pulsatility. And this is how the hepatic vein looks as well. And so here you can see that the pulsatility index of the portal vein is greater than 1. If you take the max minus the min over the max, that's going to give you a value greater than 1, so that's increased pulsatility. And this is how the hepatic vein looks when you have increased pulsatility. Now, what about decreased pulsatility? Well, that's going to be something that looks fairly flattened. So here you can see that the portal vein doesn't undulate as much as it normally does. And then here you can see that the hepatic vein has a very flat-looking waveform. It doesn't have that normal ASVD appearance to it. So that would be decreased pulsatility. So now that we have an understanding of pulsatility, let's look at the differentials for increased pulsatility and decreased pulsatility. So here we can see that the portal vein and hepatic vein pulsatility here can either increase and gives us a differential diagnosis, or can show decreased pulsatility and gives us a different differential diagnosis. So let's start with the increased pulsatility here and look at the differential for that. So with increased pulsatility, one of the things we think about is right-sided congestive heart failure. Let's take a look here in a patient with right-sided heart failure. Let's take a look at what the portal vein and hepatic vein look like in this particular patient. And so when we zoom in here at the portal vein, we can see that there is increased pulsatility, that we can see it going beneath the baseline here. With the hepatic vein, what we see is usually an abnormal tall A wave here. Usually this is just a little blip above, but this one is actually quite tall. So you get an abnormally tall A wave, and you also usually get tall V waves as well. You can see that these normally can appear above the baseline, but in these ones with right-sided heart failure, they are usually much taller. But there's also a normal here, S to D wave, that the S wave amplitude is much greater than the D wave. And that's what we see normally within the hepatic veins, and that's preserved. So the A and the V are usually abnormal. The S and the D will appear normal. And this is in distinction to the other cause of increased pulsatility, which is tricuspid regurgitation. So let's take a look at what that looks like. Well, in tricuspid regurgitation, the A wave, again, is abnormally tall, as with the V wave, so similar to congestive heart failure. But here you can see that the D wave has the highest amplitude as opposed to the S wave. So you get this kind of flip in their relative importance of flow coming in from the hepatic vein into the right atrium, that it mostly occurs during the D phase. Now, in really severe cases of tricuspid regurgitation, this S wave can actually flip. And this gives rise to what is termed the ASV complex, because the ASV are also all above the baseline here. And so in severe tricuspid regurgitation, you can get that appearance. So let's look at some examples here. Here's one where you can see there's increased pulsatility within the portal vein. Here you can see this abnormally high A wave. And then here, when you look at the S and the D wave, the S wave is supposed to be the highest amplitude in this direction, but here it's flipped. And so this is a case of tricuspid regurgitation. And then when we have really severe tricuspid regurgitation, again, we get that increased pulsatility within the portal vein, but here we can see this ASV complex, and then you get the single D wave below, and so this indicates severe tricuspid regurgitation. So that's the differential for increased pulsatility. What about for decreased pulsatility? Well, we can think normally in patients with Valsalva who are Valsalvaing, you can actually induce decreased pulsatility. Usually doesn't come across clinically relevant, but to make sure a patient's not Valsalvaing as a cause for decreased pulsatility is important. Cirrhosis is a very common cause of decreased pulsatility, and then subcardiac venous outflow obstruction, which has its own differential, and we'll get to that shortly. So let's start with Valsalva. Here's an example of a resident that volunteered to have themselves scanned. Here's the hepatic vein. Normally, we can see your ASVD waves here. Here's your ASVD coming here. And then during Valsalva, you can see that amplitude is much decreased in the hepatic vein during Valsalva. So just taking a closer look, we can see the normal appearance, and then we get that Valsalva with decreased phasicity. What about with cirrhosis? Well, let's look at the appearance of cirrhosis on the portal vein and on the hepatic vein. So normally, you have the bile ducts within the liver, you have the portal vein that feeds into the sinusoids that eventually goes to your hepatic vein. You have your hepatic artery that also has a connection with your sinusoids and drains into your hepatic vein. And so this is the normal appearance of the lobule of the liver. And so here you can get a normal hepatic arterial waveform. Here's our normal portal venous waveform, and then here's our normal hepatic vein. So what happens as you increase your resistance? Well, the first thing that happens with mild fibrotic changes, you can see the fibrosis occurring within the liver, is that your portal vein will actually dilate. And this will be seen on spectral Doppler as a decreased pulsatility of the portal vein, but also an increased size of the portal vein. So let's take a look here. We can see that there's an overall flattening or decreased phasicity to the portal vein. And we can also see potential engorgement of the portal vein itself. Some people say 13 millimeters, some say 16 millimeters, as far as what constitutes pathologic dilatation of the portal vein. As the fibrosis increases, the amount of flow that comes through the portal vein eventually becomes decreased, and your hepatic artery starts to take over the perfusion of the liver. And so what you can see within the hepatic artery is you can actually see velocity increases. And so in this particular case here, the velocity was up to 305 centimeters per second. Normally, it's going to be less than 100 centimeters per second. The other thing that we can see as well is you can see the flow, the velocity of the portal vein going down, as well as a flattened appearing waveform. And then here, because you're getting increased fibrosis within the liver, your A wave is going to be affected because it's going to have increased resistance to come back and flow back within the liver. So your A wave will actually dip below the baseline. And when it reaches halfway to its lowest point, when the A wave comes halfway to the lowest point, that usually indicates a moderate degree of fibrosis within the liver. Now, what happens when you have severe fibrotic changes? Well, a number of things happen, but your hepatic artery velocity is going to be increased. You're going to see potentially reversal of flow within the portal vein. That initially you'll get reversal of flow within the peripheral branches before progressing to the main portal vein. Normally the hepatic artery and the portal vein travel towards the liver, but because of this high resistance, you can actually get shunting of blood from the hepatic arteries backwards to the portal vein, and this can eventually, on a macro level, lead to reversal of flow within the portal vein itself. And then here you can see as you get more and more fibrosis, the hepatic vein can actually appear quite flat because the whole hepatic vein is stiff. And then eventually what can happen is you can get collateral vessels that end up shunting blood away from the liver, and collateral vessels can form. The most common collateral vessel is going to be your coronary vein, which is your left gastric vein, but you can also get recanalization of the umbilical vein as well. And so here's, again, hepatic artery showing high velocity, and then you can see shunting of the blood from the portal vein to your umbilical vein, and we'll head in that particular direction. Okay, let's look at the last category of things that cause decreased pulsatility, and that's going to be your subcardiac venous outflow obstruction. And so things that can occur are you can get obstruction at the level of the hepatic vein or IVC. That's referred to as Budd-Chiari syndrome. You can get obstruction at the sinusoidal level, which is hepatic sinusoidal obstruction syndrome or veno-occlusive disease. And then finally, you can get portal vein thrombus at the portal vein level, where you can get complete occlusion, and that can have implications about the pulsatility of the portal vein. So let's look at the first two of Budd-Chiari syndrome and hepatic sinusoidal obstruction syndrome. So in Budd-Chiari, again, it was the level of the IVC or the hepatic veins that are narrowed. Here's a very narrowed hepatic vein. You can see this flow void within it, indicating very high flow within it. If we go here, we can actually see that the hepatic vein here has got a tangled number of collateral vessels with the portal vein. It's trying to figure out other ways to get around that obstructed hepatic vein, and so therefore you get these tangle of vessels that are created with collateral vessels, and here you can see those collateral vessels on this venogram. What does it look like on ultrasound? Well, you can see aliasing at the area of obstruction or narrowing. Because you have this narrowing or obstruction, anything proximal to it is going to have a flattened waveform because it's not going to be able to communicate directly with the heart. Here we can see on this particular image here, we can see tangle of vessels here that have been created, and then you can get other signs of portal hypertension because of this outflow obstruction, including splenomegaly. Just looking at this particular image here, here's the hepatic vein. We're going to follow that down as it goes, and we can see that there's a number of collateral vessels that have formed here, and those collateral vessels communicate with the portal vein. And so this is the body trying to develop collateral vessels to get around the area of narrowing within that portion of the hepatic vein. So here's the narrowed hepatic vein that we can see right here on the MRI. Here's reversal of flow within that portion of the hepatic vein because it's not able to go easily out of the hepatic vein that direction. It's using collateral vessels to reverse its flow and eventually join up with the normal portion of the hepatic vein that is now able to drain that portion of the liver. And then finally, we have portal vein thrombosis, which can happen within the portal vein here. Here's an example here. If you look at it, there's not a whole lot of phasicity going on within this portion, and you can actually see on the color Doppler, there's not a lot of flow seen or any flow seen within the main portal vein. On the CT scan, we can see that there's an obstruction at the level of the liver, of the portal vein. There's hypertrophy of the hepatic artery because the portal vein is taken out, and this is seen as this kind of corkscrew appearance of the hepatic artery that's compensating for the lack of flow within the portal vein. So that's a quick overview of liver Doppler. Again, I think it's important to understand pulsatility, to understand the normal flow direction and phasicity. And using that pulsatility understanding, it gives us some differential diagnoses where we can understand with increased pulsatility, certain differential diagnoses of heart failure and tricuspid regurgitation, and decreased pulsatility, where we think about cirrhosis and Budd Chiari, as well as sinusoidal obstruction syndrome. Thank you.